Hey guys, it's Nurse Gwenny. I was recently dispatched on a flight, and the only dispatch information that my partner and I received was that it was a 30-year-old male with an insulin pump malfunction. And when we were on our way to the scene, my partner said, well, this probably won't be much. We'll just run some D10 and take him to the hospital. And I said, well, how do we know it's not the opposite direction? How do we know the patient wasn't getting enough insulin? And the patient's now in DKA. And my partner said, I hadn't thought about that. And so we had probably 10 more minutes until we got there. And I said, let's run through it, because we like to use our response time as a time to make a plan so that when we get there, we can quickly take care of the patient and get them to the hospital. So we walked through the plan of what does DKA look like? What are the complications of it? He was studying for his FPC. And so I shot him a couple of questions. Okay, what do we expect the potassium's gonna be? What is the relationship between potassium and pH? And we went through all of that. And we landed on scene, and I didn't really anticipate us having all of the problems that he and I had troubleshooted and planned for. So we step in the back of the ambulance, and the patient is, we'll say, somnolent. He's kind of dozing. But I can immediately tell that his mouth, his mucous membranes are so very dry, and his skin looks super dry. And as I begin talking to the patient and assessing him, and my partner is talking to the ground medic and getting report on the patient. And I'm saying, hey buddy, my name's Gwenny, I'm gonna be your flight nurse. Tell me what's going on today. And I noticed that the only thing that was on the monitor was his pulse ox. He didn't have his cardiac leads on, but they were just kind of dangling from the monitor. And I thought, what's going on here? And when I asked the patient, he just kind of, nonsensible response. And I was like, well, this is not good. And about 2 seconds later, my partner says, Gwenny, here's the strip she got on him. And I said to myself, oh dear. So I said to my partner, we need to get him loaded and go. The ground medic was unable to get an IV on the patient, and she said he was just a little bit confused, not really combative, just not following commands super well. So I looked at my partner and I said, hey, this guy's really sick. We need to get him to the hospital pretty quickly, but he doesn't have IV access and he hasn't been following her commands. So let's make a plan. Once we load him on the helicopter, if he does become combative, we can always give intranasal Versed to calm him down, and then we can move forward with getting our IV and giving the patient the medications he needs. My partner said, I like it, let's do it. We put him on our cot. We go and hot load him into the aircraft, and no sooner had we taken off and gotten to altitude that the patient was like a toddler that you had given the wrong color sippy cup to. He was just angry, and there was no consoling him. And I said to my partner, grab the Versed, let's give him some intranasal Versed that'll calm him down enough that we can get an IV on him. And then the patient starts punching at the window of the aircraft. I'm like, oh no, this is going so badly. So I'm laying on top of the patient's arms, and he was a pretty strong young guy, and I'm trying to hold him down. My partner is grabbing the Versed. We weren't even able to give it intranasal. We just had to give it IM, and it did nothing for the patient. So my partner said, I'll hold him down. You reach for the IO gun. So I reached for the IO gun. I'm just praying that, like, please don't wiggle so much that I should put this in my partner's hand instead of in the patient's humeral head. I'm able to get the IO. I push 2.5 milligrams of Versed, and the patient immediately calms down. My partner and I look at each other. And that whole time I was thinking to myself, do we need to land in a field because this guy is a safety concern? We did call out to our pilot, hey, be ready. If we need to make a landing, we're gonna let you know. But for now, I think we've got it. But as soon as the patient calmed down, I looked at my partner and I said, now the real work begins. This strip tells me that my patient had massive hyperkalemia. You just hear my dog shake. So the concern with a patient with DKA, so we know that he had been without insulin for a couple of days. His insulin pump had run out and he was not able to get more. And we know from the ground medic that the glucometer just read high. That usually means the patient is above 500 or 600, whatever your machine is calibrated to read out high at. His super dry mucous membranes, that tells me that the patient is at a massive fluid deficit, and he really requires a lot of IV fluid resuscitation. I know that there is an inversely proportional relationship between pH and potassium, and that's where this cardiac rhythm strip comes into play. I keep wanting to call it a 12 lead. It was not a 12 lead, it was just a strip, okay? And so I know that in my patient with DKA, their bicarb is rock bottom low. And then to compensate for that, the brainstem says, hey, let's blow off some of our acid. And that's why patients get Kussmaul's respirations. They're trying to blow off their CO2 so that they can achieve balance with their rock bottom bicarb. So my patient is super acidotic. And as I just said, there's an inversely proportional relationship between pH and potassium. So if their pH is super duper low, their potassium is going to be mega high. And the concern for that is that this is almost a sine wave, okay? So of course, yes, we'll get peaked T waves. Everybody knows that one. But then you get a widened QRS complex. And then a sine wave is what those patients get right before they go into that fatal dysrhythmia. So I knew we were not far off from this patient throwing a fatal dysrhythmia. So once we got the patient under control, we had IO access. The first thing we did was we gave calcium. Now, calcium tells the heart, don't freak out about this rhythm, okay? So it doesn't do anything to lower the potassium, but it helps to stabilize the myocardium so that it doesn't go into those fatal dysrhythmias. We also started a fluid bolus because, as I told you, we could tell this patient was at a massive fluid deficit. Unfortunately, we did not have time to start the albuterol pre-hospital because we were coming in on landing after we had gotten those first few things done. We also put the patient on patches because I was worried about what this would lead to. And when we got him to the emergency department, handed over care, I said to myself, I really want to get those labs and see how sick this patient is when we come back later today. And lo and behold, we had a flight shortly thereafter. We went back to the hospital. I found the nurse and I said, hey, is there any way I can see his labs? And here were his labs. Folks, I knew this patient was sick, but I didn't realize he was this sick. His pH was so low that the hospital machine was unable to read it out other than saying less than 6.8 because that's as low as the machine went. His bicarb was 0. Guys, this patient was super duper sick. And I think it could be easy to write this patient off as being intoxicated or something not as concerning as DKA. So make sure that you have got a watching eye. With my kids, I call it have noticing eyes for your patients and be looking out and put together your context clues from the patient's history, any clues from the scene where you picked them up at, anything that their family might have told you. I've gone so far as to even find things in their pockets that help me figure out what's going on with the patient. So how about you? Have you ever had a case that took a little bit of detective work and you realized immediately that the patient was super sick?